Hello and welcome. I'm your host, Ramesh Kumar, and I'm on a mission to bring value to the healthcare industry through improved transparency. And my goal from this podcast is to give you one aha moment that you can implement in your business, whether you're a TPA, broker, or an employer. In my day job, I run a company called Zaki Point Health that helps self-insured employers and their employees provide transparency, direction, and value by delivering a digital front door for the member that proactively steers them. Please like or share this podcast on your favorite podcasting tool so we can bring together a community of like-minded professionals. This program is brought to you by the Healthcare Administrators Association, HCAA. For over 40 years, HCAA has supported third-party administrators and the self-insured employer industry through educational opportunities from leading industry experts. For information on joining HCAA, please visit our website at hcaa.org. Today's episode of Voices of Self-Funding is brought to you by WLT Software, a multi-generational family-owned leader in custom claims education and benefit administration. I have personally worked with WLT and the leadership team there, an amazing set of people who for nearly 50 years have served this industry. WLT has empowered innovative TPAs with one-time implementation and seamless partner that integrates across all kinds of solutions, driving real savings in our healthcare ecosystem. I encourage you to check them out.
This is an absolute gift of an episode for you. Lee Lewis gets it. He has worked with a huge number of jumbo self-funded employers, and he's passionate about finding innovative healthcare solutions. He was a broker in the past and a TPA. What has he not done in self-funded space? Lee introduces his ABC framework: Advanced Primary Care, Behavioral Health, and Centers of Excellence. You're going to learn about why direct primary care is gaining traction in the self-funded space and how advanced behavioral therapies like TMS and ketamine can unlock cost-effective mental health care, and why centers of excellence and tiered networks are becoming essential levers for better outcomes at lower costs. From strategies to supplement traditional networks to practical steps TPAs can take to differentiate and deliver value against the BUCA carriers. This is a powerful conversation packed with actionable insights for anyone rethinking healthcare benefits in a self-funded world.
Lee, I am super excited to have you on our podcast. It's a real pleasure. I have tracked you on various things that you speak about related to self-funded employers and how they should be thinking about this. And before I let you actually introduce yourself, I have really enjoyed your LinkedIn posts lately about various things, employers and how they could do things and how effed up self-funded spaces and buying is. And then also healthcare more broadly. Your posts are authentic, they are funny, and there's something special about them. I don't know, what is it?
Oh, that's nice of you to say. Yeah, honestly, I just started writing things down that felt like it was something that I had learned or observed that day or something that had impacted me. And I stopped using AI. Those were the only two things that happened. And it's going well. That's nice of you to say. And it's great to be here on the podcast and excited to be able to share with your audience.
Maybe tell us a little bit more why people should listen to you on this topic.
So for those who don't know me, I'm the Chief Strategy Officer at the Health Transformation Alliance. It's a large nonprofit cooperative, the largest employers in the world. We have about 80 members. We have about a fourth of the Fortune 100, Fortune 200 who are members. So these are large, well-known companies like Boeing, Ernst & Young, Coca-Cola, Marriott, Verizon, JP Morgan, things like that. And so these employers work together within the co-op to help share best practices and work together to try and realign the incentives of American healthcare with the hope that we might have a shot at transforming it. Together, we have about 6.5 million lives, and it's a wonderful place to be. And then separately, I also host a podcast called Broken Benefits, and I work with TPAs and some small brokers to help bring some of these solutions down market as well. So involved all over in the space trying to help improve healthcare.
Well, wealth of knowledge here. And I know you've been a broker in the past and worked with the TPA as well. So you kind of know all sides of this game.
Yeah, no, it's been great. Being able to work at both a consulting firm and also at a TPA gave me such a wonderful perspective on the space that it has made it easier for me to try and solve problems and understand where the obstructions are.
Well, the biggest thing I want to dig a lot more deeper into is you've got these 6.5 million lives. You have the ear to them. You understand what they're looking for. And many of our listeners who are benefit consultants or TPAs or some middle market employers, they would love to learn what these big employers are thinking, how they are purchasing, what they are seeing in front of them, and perhaps what lessons could be translated into their world. So really starting from the top, what are some of these Fortune 100, 500 employers? How are they shopping for healthcare benefits? What are they looking for?
One of the most basic foundational items, one big problem that employers are seeing is that the nucleus of the entire health plan at its most base level is if you go to your regular family doctor, do you have coverage for that? And whether or not we think that that should be covered by insurance, and there's good arguments that say the contrary, the intent of every health plan today is to cover that interaction. Yet, paradoxically, regular family doctors are disappearing completely. They're being replaced by urgent care, or they're opting out of the system entirely and becoming direct primary care or advanced primary care doctors who are being paid on a value-based payment, not fee-for-service, which is wonderful. We celebrate that, except for one major problem, and that is our carriers can't pay value-based payments or subscription payments to primary care doctors. The accounting system doesn't work like that. It's like trying to buy a tank of gas with yen or Deutsche Marks in the United States. The transaction doesn't work. So the first thing that large employers are working on right now is, hey, how do we supplement so that all of these value-based doctors are still covered under our health insurance? That's the first step that a lot of employers are taking.
So these value-based, so they are doing it themselves as employers and they need help. Do they have templates? Is this an area you are helping? What are some of the things that you're seeing in value-based contracting, particularly for PCPs, I guess?
Yeah. So if you're a smaller employer, and some of the brokers, consultants, and employers who are listening today are smaller employers that are relatively concentrated, your best move is to find the direct primary care doctor, maybe a couple of doctors in your towns or cities, and just sign a direct contract with them to pay for the members who use their service. This is important, though. Some employers are like, I'll just sign one contract to cover everybody who works here. That may be fine, but don't start paying until your people actually use the service, because otherwise you do risk overpaying if nobody wants to use that doctor. So use the doctors in your local communities and you can sign a direct contract. If you're a larger employer, you're in 100 cities, 1,000 cities, you're not going to be able to go and direct contract directly with all of them. And so what we do instead is you can use an enabler who has already brought those things together. Within the HTA, we have an opt-in program that allows employers to just grassroots add coverage for these doctors all across the country. But also there are vendors who do that, like Aligned Marketplace or Hint Connect, who are also performing that service. And there are a number of TPAs who have pre-built this in. That's a very convenient way to do it, is you can just simply work with one of the TPAs who have this already in place.
So that is obviously a big trend, value-based care. What are some of the other things that we could learn from that have worked for the larger self-funded employers that should be paid attention to right now by the middle market employers?
The other ways, I like to think of it as supplementing your network. So everyone has a network today, a Buka network, for instance, and Blues, United, Cigna, and that is your standard network. And just like a standard diet, that's covering most of your needs. It really does do a good job on almost everything else. However, there are areas where you are deficient, also similar to most of our diets. And maybe you'd want to take a supplement or add some additional types of foods in order to supplement for a balanced diet. Employers likewise have to supplement their network so that they have a balance. We covered the first one, which is supplementing with direct primary care. The additional supplements, we think about it as ABC, just as a way to remember it. A is for advanced primary care. B is for behavioral health. And C is for centers of excellence in surgical, bariatric, and other areas. So covering both of those quickly. Behavioral health, you should supplement your network of therapists at the entry level of behavioral health. There's not enough therapists who are in network. You need more in-network therapists. And there's a number of vendors who will sell that to you, that will give you an add-on network of therapy, whether it be virtual or in person or both. And that helps you at the entry level of behavioral health, but also on the extreme level. On the extreme level, you need to supplement that as well. And that covers into your advanced therapies for TMS, for stellate ganglial block, and for ketamine and psilocybin therapies and other psychedelic therapies that are getting approved right now. These therapies are, in many cases, breakthrough. They work for people where nothing else has worked. They are 80% lower cost and 90% faster than going to an addiction rehab for a month. And unfortunately, even though they're FDA approved, they're often not covered in network on anyone's plans because it takes a long time for them to figure out how all of that works for coding and clarifying these different services. And so you want to supplement that as well. And then for centers of excellence in surgery, there's lots of COE vendors who will sell you a robust center of excellence network that you can use to supplement your regular PPO network. And if you add all of those in, that gives you an extremely robust, strong, balanced network that will be significantly better than what your competition is offering.
So this is great. A good blueprint here. ABC, love it. Let's dive into this behavior therapy, and you put this in two major categories. These extreme cases where the therapies you talked about, ketamine and others, 80% cost reduction, this is huge. What is the incident of that, and how should a middle market employer, 500 employees, 1,000 employees should be thinking about this, and how should they go about making sure this is available?
Yeah, absolutely. So the easiest way to think about this, well, there's two paths you can go. One is you can go to a TPA that already has that supplemental network built in. So it's already there and it's done. You don't need to worry about it. The second way to do it is for you to contract directly with the enabler who has built that network. And there's a few in the marketplace. The leader with whom we've worked a fair amount is probably Enthea, Enthea. There's also a company called First Tracks that has a broad network as well. And there are others as well who are moving into that space, like Wire Health. And so those would be some different ones that you could look at to try and contract directly or go to a TPA that already offers this. And we'll talk in a little bit about the TPAs who have pre-built these in place.
Yeah, would love to. And then you talked about the providing therapy, psychiatry, and other kind of therapies for the base. Is that remote? You're seeing that working effectively, networks, or what has been a good, effective way to provide care to employees that may be distributed or not?
So most of the vendors in this space, like Spring Health, Lyra, Modern Health, and others, they have gone out and contracted with doctors, psychiatrists, and therapists who don't take insurance or who are out of network. And they've brought them in network so that it lowers the cost and makes it easier for your people to get access. Because if they're calling in saying, hey, can I work with you? A lot of times these doctors will say, yeah, I don't really take insurance, so no. And so your people get turned away. We want to turn that around so that everybody can get access from the local doctors in their community, as well as being able to access online resources. And so signing a contract with them directly gives you the ability to supplement, or of course going to a TPA that has already built that into place so that you can have a good, robust access to therapy.
By having this contracted network and bringing some of the doctors who are not part of the network, are you seeing better usage? Are you seeing improved kind of understanding of the impact at the patient level? How are you seeing communication? How do you promote mental health programs once you do put it in place?
Yeah, good question. Communications is always hard. In fact, the manifest destiny of people who run benefits plans, once you have put in place every possible great idea, all the strategies, all the capabilities have been added and supplemented into your health plan, you have just this incredible rock star health plan. Once you have done all the things, what's left is, and the ultimate destiny is effectively a marketing genius, is that you must become unbelievably good at communicating messages to people that they understand at the right time and the right place in order to compel the right action. And that's the final challenge that is available and waiting for all of us once we've done all the right things, is learning how to communicate them in the most efficient way possible to be able to reach people in need. Nevertheless, once you have added these capabilities onto your health plan, you're going to be in a position where people are more easily getting help. They are more easily correcting for the challenges that are in front of them. And you're getting better results and having people be more loyal to you as an employer and more retentive so that you can hold on to employees and be able to really offer a differentiated, high value benefit to your people.
Maybe share some numbers. What kind of uptake you're seeing for these baseline mental health programs, and what to aspire to and shoot for in terms of usage and impact?
Good question. So when we look at the populations, most employers, so here's a few details to check yourself. Most employers have an EAP, and that is your supplemental behavioral health thing. And most EAP programs are hitting around 2% engagement. If you're below that on your EAP, then you just have maybe a not ideal EAP, or your people are harder to communicate with. Once you hit 2%, you're at the baseline normal. That's not good. That's just normal. And when we look at large sampling surveys that identify how much need there is in the marketplace, it's probably around 10 to 12% of your population in any given year ought to or is in need and probably can or should speak with somebody. Now, obviously, that's a huge increase. That's a 5 to 6x increase over what is actually happening. Two things go in people's heads. First is, isn't that going to cost me a ton of money? And secondly is, that's sad that there's not a better outcome there. And the answer to that is it does cost a little bit more money to get people talk therapy on the front end. And some of those people will just muscle through it today and not talk to anybody, and they survive, and you're not going to spend any money on them. So you got lucky. But there's a big portion of those people who do need help, don't get it, and then they become an extreme case, and they might end up with deep alcoholism and at rehab, or they'll end up in suicidal ideation and they end up in the hospital, or even a suicide attempt, or panic attacks, or major anxiety deficiencies. There are some significant challenges that come by not getting early intervention quickly, easily, and effectively that turn into millions of dollars in claims down the road. So you are actually saving money by spending a little bit more and helping people get good access up front. You should be shooting for around 10% engagement if you're doing a great job. And we see that the best large employers within HTA are hitting around 10%.
Would you also say, aside from that impact on claims reduction in the longer term, the presenteeism, the productivity, the positive kind of environment, have you guys looked at that? Is there some kind of quantifiable view on that?
We know that we're getting that in spades, but it's so hard to track that it doesn't make it into our PowerPoint decks to the CFO. But yeah, especially if you're doing something like a ketamine therapy in the place of a month at Betty Ford Rehab or Pathways or something like that, there's a significant time component there where it's 2 days instead of a month.
But overall, you're saying there's a level of impact that we can't even quantify. Even if you just look at the claims, there is plenty there.
Yeah, I think somebody really smart could probably quantify it, but I have not yet been able to do that. I haven't had access to enough data to be able to tease that out and control for confounders. But yes, I think employers are getting huge benefits out of that. It's just hard to prove it.
And then you see, obviously, centers of excellence. We talked about bariatric and other kind of surgeries. Are there categories of these planned events where you recommend having centers of excellence? And are there ways of contracting that you recommend?
Yeah. A smaller employer, if you just want to get creative, you could reach out to a local ASC in your city or town. ASCs are almost always about half the price of inpatient and offer the same services and even get better outcomes. And so it's like, hey, better price, better outcomes, more approachable. If you've got a few hundred employees and you're scattered between 2 or 3 towns, just look up the ASCs in your towns. You could call them on the phone and just get a simple fee schedule agreement with them. That sounds radical, but it's really not. It's not that hard to be able to put that in place. If you are a much larger employer, then hiring a convener to do that for you just makes a lot of sense in terms of adding in the vendors that we discussed. There's several: Lantern, Edison Health, Carum Health, Transcarent, and others will be able to provide those services, and you can find one that works for you.
The employer can do this with few of these contracts with the local provider, but certainly
these aggregators who have these centers of excellence and networks in place. How do you get the most out of these programs? What should an employer be thinking and doing? What steps they should be taking, basically?
Yes. Once you have a COE in place, whether it be through a convener or just direct with your local ASC, you need to go to your administrator and say, our plan design is this. We waive costs. We waive all the costs allowed by law for anyone who uses the COE. So it doesn't cost our employees anything to use it. This creates a wonderful benefit so that many people who otherwise could not afford surgery can, and it incentivizes people to use it because in some cases it might not be convenient. Maybe their friend referred them to a doctor who practices at the local hospital. And so they're thinking, well, maybe I should go there instead of over here. You need to create that incentive so that it's a win for the employee and a win for you as the employer as well. That's a best practice.
Sort of tiered networks with the centers of excellence, $0 co-pays and deductibles, that kind of plan design structure and ways of promoting.
That's exactly right. Yeah. Do a 2-tier in-network benefit and say, this is the premium tier with all our value-based providers. They go in this tier and we make the cost as low as allowed by law. I say allowed by law because of HSA laws. Sometimes you must pay something, but anything that is outside of what is absolutely mandatory under the law, make it free. And then you have your second tier of regular in-network benefits that you have already in place today. You don't have to do anything with it. And then there's out-of-network. And really honing in on where you can get this easy. And again, I've mentioned that a little bit throughout the dialogue here, but there are a handful of TPAs. I want to call them out because if you work with one of these TPAs, all of these things are already in place. So one of them is Reflect Health. Reflect Health is a TPA that already has these built in. So if you're looking to RFP or want to connect with a TPA that already has this in place, look up and connect with Reflect Health. Another is Mishi, M-I-S-H-E. Mishi already has these capabilities built in. Look them up and include them in your next RFP. They already have these capabilities in, so you don't have to go and sign 10 different contracts. Another is Transpera. Transpera is a TPA that has this in place as well. And then another TPA who can activate this for you is HPI, or Health Plans Inc. out of Massachusetts. And those are some TPAs that already have these capabilities in place.
So 3 out of those 4 are fairly new names. TPA industry for the last, 20 odd years, may not even have come across them. So are you seeing this trend like newer TPAs are doing this mainly? And there's a lesson here for some of the established TPAs?
Absolutely. I think newer TPAs are gravitating into this a little more easily than an established TPA. Why is that? Well, newer TPAs know that we've got a burning platform, that there's real need to get control over these costs. And they're out in the marketplace trying to differentiate themselves, make a name for themselves. And so they're more likely to do the extra work of making these additional capabilities available. My hope is that all the larger TPAs eventually get there and get there quickly because it will help a lot more people.
So in order for a TPA to really bring this ABC together really well, what are some of the auxiliary things they need to be doing, whether it's part of their playbook, whether it's toolkits or approaches, to really bring this to life?
Well, there's, I guess, a couple ways they can do it. One is they can connect. There's a firm called Theralta, T-H-E-R-A-L-T-A, Theralta, that will bundle these capabilities together for the TPA to make it easier for the TPA to add these. That's probably the easiest thing that a TPA can do, to be able to add them in unison. Another alternative is TPAs can contract directly with these different firms. And there are a number who are doing that. Collective Health is one example. I think the carrier TPAs like UMR and Meritain do have some direct contracts in place with vendors. But a good TPA is working to bring together these capabilities and make it resellable and available to its membership. And then they are looking for additional technologies to make it easy for the patient, make it easy for the employee to be able to find them. And that gets at that sort of final destination of really trying to solve the marketing and communications problem. I think once we've done every good strategy, that is the calling of everyone at a TPA or everyone at a health plan, is you've got to find ways to easily and efficiently communicate to the people who need things what the solutions are that are available, because people just don't know. And if you communicate too early, they forget. And if you communicate too late, well, then they can't take advantage of it. And so it's really finding ways to find people out in the field and get them the right communications at the right time.
That's a big tagline. Understanding those trigger events, understanding the right communication method and message and at the right time, all of that science becomes quite important here.
Absolutely. You're never going to be too good at that. But luckily, the bar is set really low. Nobody's that great at it today that I've seen.
Yeah. What would be your parting thought here? Some simple 3-step advice. If you're a TPA trying to do all of this to differentiate in the market.
Yeah. I would say, one, if you are going to Theralta, that is an easy onboard. If you are not, and you've got lots of different options that are available, I would think the most compelling thing you could do out the bat is look for direct primary care docs and clinics that are near where all of your patients are, and see if you can get an arrangement with them for them to take care of patients who come in. They would check the ID card and accept your patients. And that way you can very efficiently, and again, this is if you're a smaller TPA, you can efficiently add some direct primary care opportunity there. And then secondly, looking for a good surgical center of excellence so that you can supplement your offering with that. If you have those two things and have pretty good control at the very entry level and pretty good surgical on the more extreme level, I think that's a nice holistic offering. And then in the middle, being able to supplement on behavioral health is a massive win as well, if you can do it. And I think that's the way I might think about that. Also, a TPA, if you're a TPA and you have a pretty good concentration, it's not unreasonable for you also make a phone call to the local ASC in the middle of your population, or a couple of ASCs. You can look at your claims and see how much you're paying for things and say, hey, would you give us a deal, just a simple fixed fee schedule for your services that, maybe is around 1.5 Medicare or something like that. Most ASCs are going to be great with something like that. And then you now have a supplemental COE network that you can offer to your groups who are in that area. It's not that hard to do, and it gives you a nice differentiator as a TPA.
This is wonderful. If our listeners want to get in touch with you or perhaps even consult with you, are you open to these kind of conversations from TPAs?
Oh, absolutely. I help TPAs all the time to be able to augment what they're doing. I help large employers and brokers as well, some brokers that are looking to offer unique solutions. Delighted to be able to help however I can. It obviously, if it's just an unpaid, I'm looking to try and advance the mission. And so happy to provide answers to simple questions and easy guidance. An easy way to find me is on LinkedIn, as we discussed at the beginning, but you can also find me through the HTA if you want to send a note there and be able to connect. Either of those avenues should work.
Well, this has been really wonderful because you have really shared some crystallized ideas. People should just take this, go out and deploy some of this, and if they get stuck, perhaps get in touch with you.
Oh, yeah. No, this advice, I used to charge people hundreds of thousands of dollars to give them the advice that we just covered right now. So delighted to be able to share it at no cost. But just because it is free, don't discard it that this isn't valuable. This is absolutely what you should do and is worth, again, if through another channel, I would have charged hundreds of thousands of dollars for this. So this is great advice. Take it, use it, both TPAs to enhance your product and your offering, as well as brokers, consultants, and employers themselves to be able to do the same. And good luck out there. We need more people doing great things.
Absolutely. This has been a bomber of a value-driven podcast here. Thank you so much for taking the time, Lee. Really appreciate it.
Hey, it's my pleasure. Thanks so much, Ramesh. Take care.
Please join us again for another podcast in the series brought to you by HCAA's Voices of Self-Funding. Please like and share so we can build a community of like-minded people. And tell us about topics that we should bring to you next. Please watch your email for updates and upcoming guests. I'm your host, Ramesh Kumar of Saki Point Health.